All right, everyone. Welcome back to a brand new episode of the Preventive Medicine Podcast. Today, we have a pretty special guest. We'll get into that in just a little second. But I am extremely happy to be back podcasting. It's been a little bit of a break, but we have some amazing content, a lot of stuff that I'm very passionate about, have new perspectives on after graduating residency. And today's guest is Dr. Bo Burns. He's pretty high up there in the medicine food chain, if you want to put it that way. He's the Interim Dean of Oklahoma University School of Medicine. He's the chair of the Emergency Medicine Department, which, for those who are unaware, pretty big deal. He's also the chief of staff at Hillcrest Healthcare System, I believe former residency program director. I think you can correct me on that if I'm wrong. And he is intensely involved in medical education in general and helping out the next generation of physicians. He's also intensely involved in the leadership of a variety of organizations related to emergency medicine, community outreach, and beyond. Dr. Burns, welcome to the show.
Thank you. Glad to be here. Looking forward to it today.
This is going to be an excellent episode. I really can't wait to get into it, but first we have to hit our intro. Overcoming saber-toothed tigers and woolly mammoths, we must now face a new enemy, ourselves. With the rates of diseases such as heart disease, stroke, diabetes, depression, and many others ballooning, we must find a better solution to these modern epidemics. Welcome to the Preventive Medicine Podcast. We believe in building a foundation of health by means of prevention so that you can build the life you want and find fulfillment with no barriers. Hear from experts around the country on how to take your health into your hands. Take control and build a foundation of health for the life that you want to live. And now, here's your host, Raghav Sharma. All right, we are back with another exciting episode. Dr. Burns, welcome to the show. I guess first, do you want to tell us a little bit about yourself? Obviously, I have the introduction for you, but tell us a little bit about who you are. Ooh. And
all right, thanks. Appreciate it, and looking forward to this. I got into emergency medicine. I felt like that specialty chose me. I've always been involved in leadership. I've always been involved in teaching. I have several relatives who are teachers, and didn't really put together this idea that you could be a teacher within the medical education space. And that kind of evolved organically through leadership opportunities in my residency, where I was chief resident. And then I had the opportunity to move back to Tulsa in 2005 to help start our emergency medicine residency. And I was the clerkship director first, and then I was the residency director, and then I've been chair for 11 plus years. And just as you mentioned, just recently, I'm on day 51 of Interim Dean at the School of Community Medicine. So I'm just super excited and very thrilled to be in a position to help, not only help deploy and develop our, healthcare strategy in our community medicine to serve all Tulsans, but also to help mentor, develop, recruit the next line of leaders that are going to, that we're going to pass the baton to kind of as we go.
Definitely. There's a lot to get into, but the first and biggest question I have, maybe the listeners, and is when you think emergency medicine, you do not think prevention. You think something has happened. Now I'm going to the emergency department. So it'll be interesting to hear from you. What does preventive medicine mean to you as an emergency medicine physician?
It's so fascinating. And I've thought about this a lot over the years. Like that is the original, the initial thought. You think emergency medicine, you're just solving problems, you're putting out fires, and then you move on. You hear the term, treat them and street them. And it's kind of never liked that term, but that's, you hear that sometimes. And in reality, over time, as you watch things not work over and over and over again, then you do start thinking about preventative medicine. Then you do start thinking about where's the gap that is there for this patient to succeed, and where is it that we can deploy resources and help someone for follow-up, for preventative care, for education, for economic opportunity. And I think that one of the things that you will see in the emergency medicine space is that we need to be really creative problem solvers, and we need to be very nimble thinkers in terms of our approach to things, our approach to patient care. I mean, a normal day for us is for things to not work. that's a normal day, right? That's how things go. We call that Tuesday, right? So what we have learned to do is how do we succeed when that obstacle is placed in front of us, and that's why I've seen so many of my colleagues get into culinary and lifestyle medicine, and get into social emergency medicine, and get into community medicine, and embrace these principles, because we see that the acute care deployment of just healthcare in the ED doesn't do much long term to help our patients in the way that we would like to ideally.
Definitely. Where in your career did you kind of find this perspective? Because obviously, I'm not an emergency medicine physician. I do know people who practice emergency medicine. And it sounds like there's a point in their careers where either there's like, oh, not my problem. And then they kind of give up on it and just do their job. Or they kind of go towards your route and figure out that there's much more that we could be doing here. So is there kind of like a moment or reflection or something that happened that caused you to go that route? Or did it just kind of, this is how you grew up?
Yeah, no, I know it's a great question, and all the people that you do know in EM, they're all cool though, right?
They're definitely cool.
Yeah. Okay.
People
Good.
I know.
Good. Just want to get that out of the way. Okay. Uh, where it comes from is there's a couple pathways, right? And I think everyone in residency experiences this. And congratulations on graduation and
Appreciated.
joining the workforce, right? There is a pathway of frustration. There is a pathway of I'm frustrated. This isn't working. And that's where I try so hard to keep our residents from going down into. That is the path of least resistance. It's very easy for us to pick out what doesn't work in our systems. And really, what I'm trying to do is empower these great thinkers and great problem solvers. And how do we overcome this? So, the short answer to your question is I think just cumulatively, watching watching people come back and watching kind of challenges that people experience. And I got in the habit early on of telling people, it's a Monday. If I see them and we make a referral, I always say, hey, I'll be here tomorrow. I'll be here Wednesday. I'm happy to see you again. Please come back if you have any difficulty with follow up, and let's try again. And that is not how a lot of people see EM, but I can tell you that sort of thing is practiced a lot more commonly than we think of.
Definitely. And do you think that has kind of changed as you've grown as a medical educator, as far as the things that you're conveying to your residents over time? Like when you first started out as either the program director or whatnot, to where you kind of left it off, what kind of have you taught your residents and how did that change?
Yeah, again, it's going through that path of emotional fatigue, right? The and I always tell people, a couple rules of like IT. Don't ever send an email angry, right? That's one that makes sense. Your frustration and your anger isn't going to sustain you. That's not going to sustain you. That's not going to lead to this kind of marathon mentality and meaningful career. Your kindness and your compassion will. So how can we help people stay in that space in a challenging and a polarizing healthcare environment? And that's really what I'm trying to cultivate and develop, are these kind of thoughtful, proactive leaders who can function in this space and help our patients that need it the most and are the most, really the most fragile.
Definitely. You sound like an excellent program director. My program director was amazing as well, but I kind of wish you were there as well for part of that. For those of our listeners who are not aware, and this is probably you're probably the first guest I've had on the podcast that's an actual educator within the system. Can you briefly tell the listeners about like kind of what medical education looks like, what the stages are, and then your involvement in it, what your role is, and how that's progressed?
Sure, and a lot of people will know, like the folks that aren't in the graduate medical education world, they know what medicine looks like on TV, right? And I
Yeah,
think
the pit.
the pit, and I think the pit has been probably the most realistic version of emergency medicine that I have seen, all to the point that I don't actually watch it, not because I don't think it's brilliant, but because there's a cost associated with that, and it's like, wow, I've been there, I've felt that, but they've really gotten that on target. So what medical education looks like is you have your 4 years of medical school, right, and then you go through this process, and not to bring back any painful or bad memories for you, Dr. Sharma, but the match process, right, or speed dating, as I like to call it, right, like, so the residents pick the students choose a specialty, and then they put in a list, and they end up going to hopefully matching, it's called, or finding a destination for what your program looks like. And that can vary 3, 4, 5, 6, 7 years, depending on the specialty. And so what you do in that residency time period is much more intense training within your specialty. And that learning curve is pretty steep at first. And usually what happens is most interns, when they start in July, they look at their senior residents and they think, I'll never be able to get to that point. And they always do. And our job is kind of twofold, is to provide a supportive, caring environment for them to practice the best version of medicine and be the best version of themselves. And we do that with one proverbial hand, and with the other proverbial hand, we push them. I can't get you to grow where you need to be without doing something that's difficult and challenging. But the way you do that is, I think, what counts and what matters, and helps people.
Is there anything unique about emergency medicine as far as residents and some sort of like mentality or in some sort of skills? Obviously, there's a bunch of unique skills to the ER, but as far as like mentality that they see, because I think EM, as far as our listeners and I'm concerned, is pretty high rates of burnout just because you see some of the like hardest things to see out there, whether it's like intense trauma, some very sad cases, traumas in like babies and infants from non-accidental trauma, things like that. So how do you kind of train them mentally as far as that progression?
You have to lean into it, and you have to talk about it. If you're an emergency physician, you should not be afraid of having an uncomfortable conversation. And really that applies as a leadership principle to any leadership position. You need to be comfortable having an uncomfortable conversation or talking about things that are difficult. And people ask me all the time, what's the worst thing you've ever seen? And I think in my head, it's not a singular event, but it's things that have the potential to hurt repetitively. To hurt self or others repetitively. Psychiatric illness, addiction, abuse. Those are the things that have the potential to hurt someone and a family over and over again. And those are really hard to deal with. And emergency physicians and ER residents are really good decision makers. Like, we make decisions all day long without a complete picture. Right? Like, someone comes in and I call it undifferentiated sick. They've come in with a constellation of complaints and, physical exam findings, and we've got to sort it out and make a disposition and a preliminary diagnosis of, does this person need to come into the hospital? Do they need to go to the operating room? Are they safe to go home? And then are they going home? Do they have transportation to get home? Can they walk upstairs? Can they navigate at home by themselves? And that spectrum goes well into the certain ages of life and things like that. So there's a lot of thinking and there's a lot of decision making that's involved. And really, I think we interact with almost probably more specialties than any other practice in the hospital.
Definitely. And then I think this is probably going to be the last question relating to emergency medicine before we dive into the real good stuff of why we're talking to you today. Is kind of emergency medicine today is seen kind of as like this quote unquote failure of medicine, because these people have, unless it's like trauma or something like that, these are the people that don't have a primary care physician or whatever else may be going on in their lives, or they're unfortunately overdosed on something, substance use, whatever it is. How has that evolved throughout your career? Has that gotten worse? Has it gotten better? And where do you think that we're headed?
It's interesting that because people will say to me quite a bit, well, a lot of your patients, quote unquote, just don't need to be there. And of course they do. Of course, everyone, they all need to be there. But what they're presuming is that the acuity of the patient isn't high enough to require emergency services. But I will tell you, our patients are extremely complicated. There's a fragility that comes with complication and comorbidities, and I have seen that develop and evolve over time. We still do see the acute complaints of the gunshot wound, the sprained ankle, the broken arm, but so much of our practice has now evolved into the management of acute exacerbations of chronic disease. Right. And so again, that gets back into the preventative side. What can we do
Hmm.
when they're in their, teens, 20s, 30s to improve things in their 50s, 60s, 70s?
And that is kind of the perfect segue into the next part of this podcast, which is kind of why I asked it in that order. And you've created something very unique over there, and that is what sounds like the School of Community Medicine for medical students. Can you tell me a little bit about what that is before we kind of start diving into how it has worked and whatnot?
Sure. So, the kind of the goal of the mission of the School of Community Medicine is to improve the health outcomes for all Tulsans. There was a study done in the early 2000s that demonstrated a 15-year total life expectancy difference between one area of town versus another area of town, and that was kind of the motivation for the creation of the School of Community Medicine, and that was made possible by a very generous gift and ongoing partnership with the George Kaiser Family Foundation. Well, I'm very happy to say that number is down around 10 years now. So we're still not there yet, but we have made some pretty sizable progress. But one of the things that we have realized, and we suspected at the beginning, was that it's not just healthcare, it's not just the doctor's office. If you don't have alignment of being in the community and working on things with the community, you're not going to be as successful. And healthcare doesn't just change by what's in the doctor's office. It has to be kind
Def-
of a multifaceted approach.
for sure. Can you tell me then exactly like, so students obviously do not really practice medicine at this point, they're still learning. So, what kind of experiences do they get when they're participating in a program such as this?
So we start them out, and we just finished this last week. The School of Community Medicine Institute is a week-long kind of immersion program into what are some of the battles our patients fight. Our mayor came and spoke. The mayor of Tulsa came and spoke and said, "Look, the alignment of my office and what you are doing is 100% in trying to improve outcomes here." Our students get to tour around to different community partner facilities and actually see what it is they're doing and see how we're serving our patients, not only in the clinic, in the hospital, but in these community resource stations as well. We do several kind of low resource simulations to help our students understand what it is our patients are dealing with each day. We tour all the hospitals, we tour all the clinics, and that's just part of it. Then they have an ongoing what's called the Bedlam Clinic, which is our clinic for basically underinsured and uninsured patients, and that is coordinated with a food pantry, that's coordinated with a pharmacy, that's coordinated with social work, that's coordinated with all these wonderful resources through our great hospital partners in town on how to not only keep people out of the ED. I love the emergency department, but our care is expensive. It's expensive to patients. So, is there a way we can work with patients to minimize or eliminate those costs to them? And that's a great space to do that. And the students do that kind of ongoing all the way through school. So it's really this kind of mentality that starts at the beginning and it carries with them all the way through. And it's really embraced from an organizational standpoint, from the very top levels of leadership all the way down to the clinics and every faculty and staff member. It's really pretty phenomenal.
Yeah, I'm going to add on to that with a personal experience. So, when I was a medical student in Chicago, I got involved with a project kind of very similar to that, where it was kind of the main point was getting people on the west side of Chicago, which is an underserved, underinsured type of area in Chicago, to get them to move, hopefully, to like influence some sort of exercise and just generally becoming more active as a way of hoping to reduce morbidity, mortality of the community. Similar stats with like the 15-year life gap and whatnot. And just getting out there as a student in those areas was incredibly eye opening to see how differently some people live, even though we might be like 3 miles apart, which literally my apartment at some point in Chicago Medical School is about 3 miles from there. And it's just so different. And I think as a medical student, if you don't get that perspective, or at some point in your training, before you've hit some sort of point, you don't get that perspective, you will never really understand what that's like. And then I think the difficult part for us as physicians is if you never have that perspective, you can be in a clinic room, you can be in your scenario in the emergency department telling your patient about, oh, you should eat better, oh, you should do this, but you never realize this might not be accessible, might be too expensive, whatever it may be. So I can say that programs like that definitely are transformative.
Yeah. Yeah. And, and one of the ideas I like to explore with our students is, and I'll hear this word and it always bothers me when I hear the word non-compliant. So I always say, what does that mean? Let's unpack that a little bit. Well, they didn't show up to their appointment. Okay. Why? What are the reasons that could be? Because I think sometimes in health, in a provider's mind, they think that person chose not to show up. They're not valuing my time. They're at home playing PS5 and just having a great day. When in reality, they may not have transportation. They may have a job that will fire them if they miss that job for the appointment. So these are real life scenarios that are significant barriers to access and care that, the sooner we can open our students' eyes to this, the more they understand that and the more they anticipate that with every next patient encounter.
We want to take a quick break to remind you that this podcast is not intended for medical advice and is for educational and informational purposes only. We also want to remind you of our Instagram page at PreventPod, where we share various content relating to each episode that you can share with your friends if you enjoy our episode. And lastly, don't forget to sign up for our mailing list so you know right away when an episode goes up at www.thepreventivemedicinepodcast.com. And with that, let's get back into this episode. So I'm absolutely loving everything that we're talking about. And obviously, it's incredibly important for students to get kind of awareness and understand how kind of the world works to some extent. But now the question is, and the problem becomes, when we all become physicians, there's only so much time in the day. There's only so much time we can spend with each patient to talk about these things. So for example, when I'm in clinic, I'll have about 15 to 20 minutes for a follow-up appointment. Now, let's say a patient needs a new prescription of physical therapy for whatever it is. Let's say lower back pain in my context. They say they don't really have transportation, so they can't really get to physical therapy. Now I have to find ways for physical therapists to come to their house, or find ways for someone else, whatever services it may be, whether it's physical therapy, whatever, to either come to their place or to arrange for that. And that takes time. Next thing you know, I'm behind by like 15 to 20 minutes, and that's a whole appointment. And then it just stacks on. So kind of how do you think this translates from being a student, just having awareness, to putting it into actual practice?
It's such a great point. And, that it's so interesting how we, on the clinic side, those time slots are very valuable, right? And it just can add to frustration and patient experience can suffer when you're feeling that pressure. I think the way that I like to frame that is, if you're trying to do all of this by yourself, you're not going to be as successful as if you're at a multi-specialty clinic or at a system that kind of embraces some of these things too. One thing I will tell you is physicians are not as efficient at this as social workers, case managers, things like that. And I know that's a finite resource and not every clinic, has those, but it's because of those things that more EDs have social workers now. That's why you're seeing the implementation of social EM programs in conjunction with social work degrees is to help bridge that gap. When I was a student and a resident, I used to think that 90% of my time or 100% of my time was the actual practice of medicine, when in reality it's resource utilization and how can I help our patients connect with the things that they need to do to get the care that they need. One of the things that we've done, if this helps at all, is once you start reaching out and talking to your community partners, you're going to find out really quickly that I don't care where you live, there's going to be resources out there you have to go into it with an open mind, because you will be shocked the great things that are going on that you may not have even known in your own city. And that's one of our initiatives right now, is to really get everybody on the same page. We know that our resources are shrinking. Unfortunately, there's not a line of people out in front of our medical school or our clinic waiting to pay us more money for patient care, right? So we have to be better at engaging our philanthropic resources and our nonprofit resources as an outpatient. But the way you do that is you have to engage them and work with them and find out what's out there. So to your point, you may not be able to fix that at time zero, uh, but doing some investigation and searching around your community and what are the resources that are available is probably worth looking into.
Social workers are definitely extremely valuable. Working in like the inpatient rehab unit during residency, they provide so much assistance to patients. But the question then becomes, do you think it's up to physicians and like those who practice medicine to take care of this, or is this something we should rely on other partners such as social workers or healthcare consortiums, systems, whatever it may be, to kind of deliver that care? Do you think this is something that should be off our plates and we should just be aware of it, or is it something that we should actively be trying to do some of it ourselves at least?
My thought on that is what would be the most efficient use of time to get that patient what it is they need. And there's going to be some things that you know exactly what needs to happen, how it needs to go. Boom. Okay, you can do that. There's some things that your social workers, if you have them in your clinic, they can. And I've seen our social worker, name drop Tracy, in the ED. She can do something in about 10 minutes that would have taken me 2 hours. Right? I mean, so my answer to that is, what's the most efficient delivery system to achieve the goal?
Definitely. You also mentioned something else in there, which is people aren't lining up outside to pay us money to do these things because this doesn't make the healthcare system or insurance companies or anyone money. So, as far as incentives go, how do you think that incentives can be aligned better to kind of facilitate this and help patients kind of navigate not only the healthcare system, but their communities and the resources that they have access to?
There's been a lot. You have to think about the time scale a little bit. It's a little different than you might think. So there's some good research and some good literature on implementation of social workers in the ED. Well, originally the thought was, we'll put a social worker in the ED. It will decrease unnecessary. That's always my favorite word. Unnecessary ED admissions. I'm saying that sarcastically, but it didn't. It didn't decrease the admissions, so they thought it was a failure. It wasn't a failure because what it decreased was the second admission. What it decreased was the bounce back type phenomenon. So you have to, in terms of quantifying the value of an intervention or a person or a job or a role, you have to make sure you're looking at it in the right time scale at the right time to capture the most value for it.
For sure. And then kind of jumping onto that into as far as like the community outreach portion, we've kind of touched on hospital systems employing social workers for these kinds of things, probably getting huge savings from preventing secondary, tertiary, whatever those admissions are. But then when it comes to actual outreach of stepping into the community, this is, let's say, a physician on their time, and physician time is valuable. We deal with so much. Where are the incentives for this kind of thing where we have like a group or whatever of physicians, social workers, whoever go out into the community and actually kind of create that bridge and create that connection with the community?
I will tell you, be very transparent. I'm extraordinarily spoiled in this area because our faculty and staff have just embraced this so much. And Tulsa is such a great community, and our faculty could all. I hope they would never do this, but any of them could leave tomorrow and have a job anywhere else. So they have selected to stay because they believe in the mission and they believe in the value of what we're doing. So when I see our faculty, our staff, our residents volunteering and doing things in the community space, it just makes me happy. But there's also a very distinct message that I want to make sure is out there. We're not saying we're going to go do things for the community. That's not our message, and that is a message that I think unintentionally will not land well. We're doing things with the community. In employing people that live locally, our faculty living locally, engaging with community groups close to these clinics is important because we have to confront that there's some mistrust of the establishment of medicine. So how do we fix that? Well, first of all, or how do we address that? Number one, we have to know that it's there. Number two, we have to confront it and get into a space where we can interact with people and talk to people, and they say, "Oh, you know what? that's a normal human. Maybe I do want to come see them in the clinic and establish a relationship with them. So it's very much a partnership, in terms of deployment and engagement.
Yeah, as a kind of quick side note, one of the things that I'm obviously much younger than you, much less experienced in medicine, but I think one of the things that I'm starting to notice is that as physicians have kind of escaped into not escaped, but been more employed by academic institutions into quote unquote ivory towers of
Right.
whatever the institution is, they've kind of withdrawn from the community because before there was many more community physicians out with their own practices, whether it's family medicine, even emergency medicine, whatever it may be, and now they're kind of retreating, so it kind of takes away some of that connection that there was with the community. And now to really access and see a physician, you have to go to this huge big center, which already probably is riddled with mistrust because it's this big center of who knows what they're doing behind there, who knows what's going on in the lab.
Yeah, no, no, you're exactly right. And again, I think one of the things I tell the residents all the time is you never meet a stranger in emergency medicine, right? You have to be able to be really good at making an authentic, organic, very real connection with somebody, probably on not one of their best days. And
Mm-hmm.
so I do think having a conversation, saying someone's being discharged, okay, this is where I want you to follow up. Will you have any trouble following up? This is very important to me. What can we do to help you in this area? How can we achieve this goal together? Again, I think there's a whole lot of we in this space and a whole lot of us in the conversation. And I don't mean that as I don't certainly don't imply that as any kind of something that's not authentic or anything like that. I believe our patients know when we care about them, and we understand that this is something that's very important to us, is to see the best possible outcomes.
Definitely. Now, this may be the $1 million question. You mentioned the mayor of Tulsa at some point, and we've mentioned pretty significantly the role of physicians, healthcare systems, social workers, whoever may be involved in this outreach. But now the question is, how much of this responsibility is on kind of the field of medicine and those who practice it versus that of kind of the local, state, and even bigger, like national governments, kind of assisting those? And obviously, that's a huge question. You can break it down however you want, and we'll go from there.
Well, I mean, so you have to think about what are our safety net organizations, right? Like there's a lot of things that are safety net, and your municipal government is one, right? Your healthcare systems are one, your family unit, your community where you live is one. And I'm again really spoiled in this area, and this is why I love living in Tulsa. The Mayor Nichols this week announced that the development of the creation of the Office of Wellness and or Health and Wellbeing, excuse me. And so this idea that, again, healthcare is not, improved outcomes is not just healthcare. It's economic opportunity, it's educational development, it's public safety. And one of the things he brought up in his press conference this week was you can't tell someone to go jog or walk if there's loose animals in the neighborhood, and you can't expect that to happen. So I'm extremely excited about this kind of era that we're entering, where we have not seen this level of messaging from city government, from the mayor's office before, in a deliberate kind of attempt to solve some of our housing issues, building homes, increasing businesses across all zip codes in our town, and just improving opportunities. So the short answer is whoever can get it done is the right answer, right? And really what our goal is, again, is to make sure those lines of communication are open between our city leaders, between our hospital foundations, who are all the hospital systems in Tulsa are extraordinarily generous and work very closely with us. And I've got really great relationships with them, working with them and working with the School of Community Medicine to make sure that we're not duplicating things and that we're not doing the same work and diluting it somehow. So it's pretty exciting, and excited about what this is going to look like in the years to come.
Definitely. It sounds like Tulsa's headed in a great direction. And it sounds like it's definitely made or done the work to kind of bridge that gap between the community and healthcare. Obviously, you can only speak to Tulsa given that you're there. But this all seems kind of difficult to understand when you see the national landscape of things, where the government is not really aligning with healthcare in places. In fact, it seems to be sowing more mistrust in healthcare and kind of separating the two out. Is there anything you have to add to that as far as like where do you see this on a larger scale outside of Tulsa?
Yeah, one of the biggest compliments that we get is at the School of Community Medicine is when one of us is engaging with a leader from a very, like you mentioned, like an ivory tower type institution somewhere across the country, and we explain what we're doing, we talk about what they're doing, and they say, why don't we do that? We should do, why aren't we doing that at our place? And so that's always kind of music to my ears. But the way that you get through the noise is you stay true to doing what you do, staying true to your mission. And and you've seen this, that noise. And I don't mean to downplay what's coming out of Washington D.C. It's always important, no matter who's there. But it will change. It changes, every few years, and what we're doing is not going to change.
Yeah, I know I had a couple of physicians on from Boston Medical Center, I believe, a while ago on this podcast. I don't remember what episode number it was, but they were doing something very similar in Boston. I think it was called the Health Equity Accelerator, where they're trying to essentially get involved in the community and find ways to create those bridges so that they're not just delivering healthcare in the hospitals, but they're kind of working with the community to increase health outcomes, just decrease morbidity and mortality. Do you know of like, is there a national consortium or something of hospitals and healthcare systems that are trying to do this thing, or is it just kind of, hey, they're doing something cool, maybe we should?
That's where I think we're headed. Because I think the more success that we're having with these types of programs, I think you're going to see probably the more formalization of this type of organization or group, and almost like a best practices kind of situation. If there is one, I'm not aware. If there's one that exists formally, I'm not aware of it. But if any of your listeners know one, I'd love to hear about it. Because really, at the end of the day, we're all trying to, I think, accomplish the same things. And one of the things that I will tell you is people that work in this space, the term, just there's a leadership that exists in this space is very open to feedback and suggestions of how we can improve, right? So, sometimes we hesitate to give recommendations or advice in the healthcare space because someone may be an expert and they don't need your help or whatever. But in this space, I've found a lot of collaboration, and it's very refreshing, to be quite honest.
For those that are kind of newer in the pursuit of medicine, either they're in residency or they're like freshly graduated to becoming attendings, is there something you would say to them or give them advice as far as being able to bridge these gaps?
Yeah, I think that's a great question. And again, this gets into something I said earlier, kind of my mission statement as the dean, as the interim dean, is to, and again, just develop thoughtful, resilient leaders who are able to thrive in a polarizing culture. And what that means is we know there's going to be obstacles. We know there's going to be challenges. You need to expect those. Don't let that dissuade you from what you feel strongly about, what you feel, driven to do or guided to do, because sometimes it's going to feel like, and I'll be honest, like your listeners may be hearing me talk and thinking that guy is a lot of rainbows and unicorns. I don't know that we're actually talking about reality here, but I'll tell you, I still work shifts in the ED. I still work. I'm feeling it at 1 a.m. I see it. But I'm choosing to still do this work. I'm choosing to have the attitude of trying to make a difference and trying to be helpful in this space. And that's what I would encourage the students to do too. Don't be discouraged by, don't be discouraged when things don't go right. If you feel guided to do something, then you need to stick with it, and you'll be glad you did.
And I think throughout this episode, you've mentioned kind of the tenets of preventive medicine, but I guess it's kind of wrap it all together to put a nice little bow on it. Let's say someone does come into the ED, or you're in the community, and someone asks you, "Hey doc, how do I get healthy?" What do you tell them?
So what I tell them is, well, what does that look like to you? What do you do now that's healthy? So let's celebrate what you're doing now. There's something that you're doing. Let's celebrate what you do now. And I think about it too, is it's not a task list, it's a mentality. It's everything. It's every choice you make. It's everything. Food is medicine, right? It's every choice you make. It's everything that you do. And I always also tell them, that you're going to have some goals and there's going to be some obstacles. There's going to be some setbacks. Please give yourself some grace in your pursuit of this. I've seen so many people try these, crash diets and crazy things. I'm never going to eat a carb ever again. And those things are just not very realistic. So I think it really is a mentality, but you can't make those choices without education. And so you have to couple that with some good teaching and some good resources. I'm very spoiled. Again, Dr. Lori Whalen is our director of culinary medicine, and she's one of our emergency physicians that she started this program at our school. And so we can refer them to one of their cooking classes where they learn about nutrition and they get on track to do all this stuff. So you have to be willing to meet people where they are. Don't kill them with information. Give them access to resources. I show people things on their, let's do a Google search for this, or let's do a Google search for that, and I show them a lot of resources online that help too.
Definitely. And you said not eating any carbs. Meanwhile, today is my extremely high carb day as I'm training up for a long run this Saturday.
Yeah.
So that'd be terrible.
Yeah.
But also, I have to ask you about this culinary medicine. Can you tell me a little bit more about that? Because you just dropped that near the end, and I hadn't heard anything about this. What is that?
Well, so again, one of our emergency physician, our original faculty in our emergency department, our training program, she was watching this failed paradigm over and over and over again, and people aren't getting better. And the illustration that she uses in her talks are two people mopping the floor when the faucet's on the sink and it's just overflowing. And so basically it's this, the culinary medicine is vegan cooking, vegan lifestyle. It's been shown to reverse coronary artery disease. They do cooking classes, they do prep classes, they do cutting classes, they do all this stuff for the community. And it's pretty phenomenal of what it has allowed, how it has kind of broken down some of these barriers of this is a way to start your journey that's not in the clinic. Because just like you said, there's no time to talk about nutrition when you're trying to see your patients and try not to get behind. And this is a great way to kind of bridge that gap.
Definitely. I might be stopping by Tulsa to check that out because that is absolutely incredible.
Yeah.
Dr. Burns, thank you so much for coming on this podcast and this episode. It's been an honor to have you on and kind of talk about a lot of this. It's a topic that's near and dear to my heart. I think community outreach is the basis of preventive medicine for us physicians and for healthcare. I think it all starts in the community. There's not much we can do in an exam room or in a clinic room and what's given. So once again, thank you so much.
Thank you. Really appreciate it.
All right. Take care. Thank you for listening to this episode of the Preventive Medicine Podcast. If you enjoyed this episode and want to help us spread the message of prevention, first off, rate and review this podcast. Second off, you can find our content on our social media platforms at PreventPod. That's PreventPod. Thank you for listening, and we'll see you in the next one.